You're listening to Med School Radio, bringing you the best in medicine. Welcome back to Med School Radio. This is Simon in Tokyo. We're going to go over some more USMLE topics. Today we're going to be reading some MCQs from osmosis.org. So let's go ahead and start with this MCQ. A 14-year-old girl comes to the office because of a recurrent earache for 3 days. Medical history includes the absence of menarche. A girl states that the pain started in her left ear and then became bilateral. Otoscopy shows red, injected tympanic membranes bilaterally. There is also low ear implantation and Tanner stage 1 breast development. Cardiac auscultation shows a crescendo-decrescendo murmur which is heard at the left of the sternum between the first two ribs along with a systolic click. The lungs are clear to auscultation. Which of the following is the most likely diagnosis? A. Polycystic ovary syndrome. B. Klinefelter syndrome. C. Turner syndrome. D. Fragile X syndrome. Or E. Marfan syndrome. And the answer is C. Turner syndrome. So why was it not Klinefelter syndrome? Patients with Klinefelter syndrome have an XXY genotype. Therefore, they show a male phenotype. In this case, the patient is a girl, and therefore the diagnosis is not possible. Why wasn't it polycystic ovary syndrome? Symptoms of polycystic ovary syndrome include irregular menstrual periods with or without heavy bleeding, excess body hair, and high levels of androgens. How about Fragile X syndrome? Although recurrent otis media can occur in patients with Fragile X syndrome, they have normal menstrual periods. In later life, they also develop premature menopause. Why wasn't it Marfan syndrome? Marfan syndrome is not a cause for primary amenorrhea. Patients are characteristically tall with arachnodactyly, and the characteristic heart complications are mitral and aortic valve regurgitation. So the major takeaway here is that Turner syndrome can be diagnosed prenatally by amniocentesis and chorionic villus sampling. However, postnatal diagnoses are also common and generally occur in puberty when there is amenorrhea. So what's the main explanation of this question? The patient has primary amenorrhea because of Turner syndrome, which is 45X karyotype, sometimes XO. Physical characteristics of this syndrome include low ear implantation, webbed neck, broad chest, short stature, and obesity. Recurrent otitis and hearing loss are also common, along with kidney and heart malformations. About 1/3 of the patients have kidney abnormalities, and up to 15% have a bicuspid aortic valve, which often leads to aortic stenosis, as seen in this case. Aortic abnormalities are also common in these patients, with estimated prevalence from 9 to 42%. Estrogen replacement therapy has been used as part of the treatment since Turner syndrome was described in 1938 to promote the development of secondary sexual characteristics. Estrogens are crucial for maintaining good bone integrity, cardiovascular health, and tissue health. Women with Turner syndrome who do not have spontaneous puberty and who are not treated with estrogen are at high risk for osteoporosis and heart conditions. So there we have it, a question from osmosis.org. I use osmosis to prepare before lectures and also to generate MCQs before exams, so I recommend you give it a try. So thanks for listening. Let's listen to Led Zeppelin, Bonheur.